Hello everybody. Very nice for you to join us today for the webinar on improving patient care pathways. My name's Claire Cordeau. I lead the healthcare team here at Simulate, and I'm going to be speaking to you today about some of the work that's been done in pathways and some of the opportunities that we've got for you to get involved in some of that. So what I want to cover is how we understand patient care through pathways, just some of my learning through my career in healthcare, how simulation can help that, some examples, and how we can start to think about using these pathways as standards of care and sharing them across the community. So rather than having to develop the same pathway multiple times, actually being able to share one pathway numbers of times in order to share some of that learning, and we'd love you to get involved in that. So something about patient care pathways then. As anyone involved in patient care knows, that they are routinely used to understand and improve our practice. And one of the things I've been interested in looking at is how people develop these pathways and whether there are common ways that we start to think about patient flows and activity. And I've defined these as services or clinical practice or disease, and I'll explain a little bit more about what I mean by those. So in the first example, we're looking at services. So here you see a process flow through services going from the primary care physician or the GP through to the outpatient, into diagnostics, through to treatment, which might be in an outpatient clinic or might be as an inpatient, out at the other side, and being followed up in outpatients. So that's very much looking at the sorts of services that a patient might access as they go through their pathway. And that's a useful way to do it, so particularly when we're looking at the activity that we're likely to see in each part of the process and how that flow works and whether we've got capacity to be able to manage it. Now, a second way of looking at pathways is about best clinical practice. So I've got an example here from the Map of Medicine, which is looking at all the most recent research on treatment for a particular condition, and it's designed to be used by a clinical decision maker as they presented with a patient with particular needs. It's got lots of notes underneath it, which allows you to understand all of the different research and what is involved in the history and the examination for that particular patient. And it allows you to understand how that flow works, but it's very much based on a clinical flow. And then the third type of pathway that I wanted to look at is the disease progression, which is about how patients move through a system according to the way in which their disease progresses, so through disease states over time. And you can see there the example of HIV infection, where you have an acute clinical event which might end in death, go back to chronic HIV infection, and it all starts from primary HIV infection. And there are different probabilities for how a patient might move through those states, which will determine the kind of services that they need and the sorts of costs. So that's very much a disease progression. So I've identified those three types of pathways, and you'll probably be able to think of others. But having simulated pathways for some time and worked with a number of our different clients to do so, we've developed an approach to simulating pathways, which really is trying to combine all of those three approaches, so combining disease state transitions with clinical best practice and with access to service. So why are we interested in doing that? Well, because you can test the impact of your new interventions, your innovations, any redesign on how diseases progress. And because actually disease progression behaves in very much the same way, regardless of where you are in which country in the world, but it's the interventions that mean that it either progresses or doesn't progress, or you're cured, then if you start with the disease progression, it does allow you to make that pathway more generic, which means it can be used, localized, reused by any group who's interested in improving pathways for patients with those same conditions. So we've learned that starting with the way in which the disease behaves and progresses is probably the most effective way of doing this if you want to be able to share your experience and your understanding with other people. So I wanted to look at disease transition in a little bit more depth, and this is an example of wound care, and it's showing how people move from being in an uncomplicated wound state to either having a healed wound, which is of course the desirable outcome, to possible death, to having a skin disorder, clinical infection, severe infection, becoming very ill. And depending on the sorts of interventions, the kind of treatments that people are getting, then the longer they stay in that uncomplicated wound state, the more likely they are to have complications which come from that. So the quicker you can get them into the healed wound state, the better it's going to be for that patient. And it allows you to understand how that progression works. And of course there are different interventions at each stage and different resources are used at each stage. But starting from that state chart allows you to start from that progression for each patient based on those rules. So what we do then is we link the disease transition to that disease transition model, a discrete event simulation model, so that whilst you're in that clinical infection state, for example, you can go into a discrete event simulation model which models the types of treatments that you might get whilst you're there. And as soon as you move into a different state, then that new state triggers a different model. Now, we've just showed that in a very simple way there, but hopefully that explains quite simply how combining that disease transition model with the treatment model and a service model can help to combine those different areas. Then coming on to clinical practice, of course, once you've got your disease transition model and you've got your interventional service model, you can model your as-is service and understand why it's happening in the way that it does, and then you can test out best clinical practice, your new interventions, so you can see what the impact is on cost, resource, activity, waiting times, and also disease progression and therefore outcomes for patients. So this way of looking at pathways enables you to understand patient outcomes as well as the kind of key resource questions that you might be wanting to answer. So I wanted to give you some examples of that, that kind of concept of modelling pathways to explain how this works in practice. And the first case study I'm going to start with is an HIV case study. And what we're looking at here is what the impact of screening is on HIV activity and on patient outcomes. And the second scenario we're looking at is what is the impact of increasing frequency of attendance to improve adherence. So the assumption is if you're able to offer more frequent service, then those patients who might be more reluctant to come back for treatment actually adhere to that treatment better. And what we want to see is the impact of those two things on the future burden of disease and also projected treatment costs and, in fact, capacity requirements for the service. So this is a case study we've been running with one of our clients, and the way that we started it was to look at age-banded projections in the population. So we were starting with the population in a particular catchment area. We can see there the age breakdown within that population, and we can associate the likely disease prevalence for HIV with that population. And so as the population ages, they have the likelihood of having HIV. We've used the age-bounded disease prevalence of 0.465% for HIV, which is based on the published data. And in this particular population, that gives us a demand of 2,531 cases, which we've actually validated with the published data. But rather than starting with that 2,531 cases as our arrivals, we've preferred to create that calculation behind so that it's producing that number, so that as we roll the simulation forward year on year, we're taking into account the impact of changing demographics. So actually, in this population, the projected population is decreasing. So in fact, the population is increasing overall. But when you look at the key groups, 25 to 54-year-olds who are most likely to have HIV, then you can see that actually over time that group is decreasing. So we ought to be seeing a decrease in that condition. But of course, we know that actually people who are not diagnosed, who have HIV, have a likelihood of infecting others. So we know that our demand is not just going to be based on the population, but it will play a part. So how we've modelled this, and we've used our population health tool, which is used for strategic planning purposes, scenario generated to do this, is we've looked at our patients who are diagnosed or undiagnosed, and you'll see the undiagnosed part of the pathway here. Now, the research evidence says that 25% of patients are undiagnosed, and you can see that they go to this undiagnosed step here, and then what they're replicated. So we have, for each patient that is undiagnosed, they have a probability of infecting somebody else, which again may or may not be, may be undiagnosed. Again, that 25%. And that comes through again, or may be diagnosed as a new infection. But whilst that undiagnosed group are not presenting, they have a likelihood of becoming symptomatic and very sick. So we've sent them through to that part of the pathway. And we've got an option here to have more screening that brings more infections in. And I'll come on to the results from that later. So on the undiagnosed part of the pathway, we've got the 75% of patients that are diagnosed. And there are three routes for that, and I'll come on to this middle one later, but there's the group that are having successful antiretroviral therapy, and we're assuming that they are being regularly followed up until a death which is near their normal life expectancy. And we've got the group that are not in treatment and are likely to infect others. And so we've said that, again, they're replicated so that they have a possibility of infecting others, but actually slightly less than if they didn't know that they were HIV positive. And then they go through to becoming symptomatic, and each time, this is a year wait, so there's a cost incurred each time they route through that year, and then eventually they go on to AIDS. So what we're doing then is modelling at the potential burden of disease if people are not treated, and also the activity and costs if people do go through to treatment. And this enables us to vary those inputs and to experiment with what will happen if we're able to get more people diagnosed and more people into treatment. So we've put some costs in there. They're indicative only at this stage, but just to allow us to test out what the impact might be. And when we run the scenario through for 5 years, you can see the activity results, and you can see the number of new infections, the number of people in ART, and the number of follow-ups. And the follow-ups, of course, go up and up each year as more people stay in the pathway, and those results represent no change for the next 5 years. So that's our baseline. Now, our first scenario is saying, what if we increase our screening, and that reduces the undiagnosed patients to only 15% rather than the 25%. And you can see the costs here, the results here of that baseline compared to screening. So in this far left graph here, you can see the costs the baseline costs year on year as against the cost of screening. So what's interesting about that is it's slightly less in year 1 and 2, increases in year 3, and actually the overall costs of the baseline start to increase by the final year, and that's because fewer patients are developing HIV symptoms and AIDS by that point, and actually the costs of screening is proving its worth by that point. When you look at follow-ups, you can see that in the screening scenario, which is that red bar there, you're getting more follow-ups as you'd expect than the baseline, although in year 1 it stays about the same. And then when you look at how the baseline for people with AIDS compares with the scenario for people with AIDS for the screening scenario, and again comparing HIV symptoms for the baseline scenario with the additional screening scenario, you can see that actually symptoms are starting to reduce, number of people with AIDS are starting to reduce quite significantly by year 5 as a result of that screening. So costs are decreasing over time as fewer patients develop HIV symptoms and AIDS and fewer infected, but of course your follow-ups are increasing, so we are going to have to manage that additional capacity, and again I'll come on to that. So our second scenario here is what happens if we see patients every 3 instead of every 6 months, and as a result of increasing successful ART. So this is this middle pathway here. So we've got our successful ART group going down this route here. We've got people who are not in treatment, and then we've got this new pathway here, which is saying that actually we're going to see people every 3 months, and that's going to have a similar success to those people who are already in successful ART but being seen every 6 months. And what we're going to do is to take a small proportion of the people not in treatment into that supported pathway and see what happens. And what we're seeing here as a result, and this is comparing these 3 scenarios, is that actually that last scenario does increase our cost. So on that left-hand graph here, you can see that actually that supported ART costs over by year 5, in fact each year, is increasing our costs overall. But actually the symptomatic patients do reduce in that last scenario, again, quite significantly. So look at year 5 here. For the number of people with for people in with symptoms, you can see they are decreasing with that additional treatment, and also you can see that new infections are decreasing as well. So from a patient outcome point of view, that's a really good result. So then the question is, all these scenarios are showing us that we're getting great results for patients, but what resources are needed? And you can see that for each of those scenarios, we've got these increasing number of follow-ups. Now we started in our baseline with having 100 weekly appointments and ran that through for the 5 years, and you can see that those wait times are unacceptable. I mean, even with that 6-month average, you've got people waiting 295 days on average. That's not really going to work. They're not going to get treatment regularly, but actually if you increase the weekly appointments to 250, that brings your wait times in line with the requirements. And what I really wanted to bring out here, this is obviously a specific pathway for HIV, but what it's doing is it's combining the disease progression with the service interventions, with the capacity and the types of services you might need. So it's bringing all of those things together. And in fact, that sort of scenario can be reused because it's based on the research evidence of disease progression, which means that it's possible just to put a new population into it, make sure it's validated, and the numbers coming in at the start are right, and you can just change the proportion of people that are diagnosed in your area to get a valid baseline, and then you can rerun that with new capacity requirements and the resources that you have in order to get a result for any community that you're working with. I also wanted to show you a similar case study, but this time looking at dementia. And I'm going to move over to the actual model now to show you this. Now, this is dementia care, and again, it's got that disease progression at the top here. I'll just set that running to show you. And we've got the progression from mild to moderate to severe. And whilst patients are in each of those states, then they have these different sets of services. So what it's enabling you to do is to understand how patients progress, when they progress, what services they're going to need, and when they're going to need them. And we've got the clock running on the right-hand side here. I'll just speed that up a bit. And it's going to run for 3 years to allow us to understand how that's going to happen over time. One of the reasons we looked at this particular model was because very often some of the predictions about dementia are talking about the number of people with dementia, but in discussion with different healthcare providers and planners, we thought that really people needed to understand that in terms of the stage of dementia that people are at, because obviously not everybody who has dementia is going to need home care and residential care, and there's a whole sort of spectrum of different requirements at different points as a result of that progression. Now that's run through for 3 years, and we can have a look at the activity results here for each of the states as we've run through. And we can also, so we can see how that progresses over time, and then we can look at the cost results against each of different types of services that people might be accessing whilst they're in that disease state. Now, the way that this model works is that you're able to select a population, and then you can look at the different the detail of the simulation. So what we've got here is condition types. So we're looking at the different types of conditions and how that affects people at different age bands. So when you put in your population, your age bands, much like the HIV example, you can see that as people age, then they're more likely to progress and have different types of dementia, and that changes whether you're male or female. We're also looking at the severity of dementia here, so we're looking at mild, moderate and severe states, again by male and female. We're also looking importantly at progression time. So we know that there is we've used a triangular distribution for this. So in the model, the rules will say that if you're in a mild state, then you'll probably be it'll be about 3 years before you move to the next stage, but of course there's some variability. And you'll notice in the model that we have people who are diagnosed and people who are undiagnosed, and we have a slightly different probability for those people who are undiagnosed and not receiving treatment as to their likelihood of progression. The next part of the detail then is looking at incidence and prevalence, and that's being used in the model as well. So of course we're looking at that total prevalence, but also that incidence. And also we start the model with people in their current stage of diagnosis, whether they're diagnosed or undiagnosed, whether they're severe, moderate or mild. So from day one, you've obviously got people who are in this model. Now all of that really are the rules that govern how people move from state to state in the model, and the services that they use. And then you can edit those services as well. You can add more. You can change the costs so that you can localize this model to your own community, but you can keep the thinking that's gone into this progression, which enables you to modify it for your local community, but also to make the changes that you want to. So the idea is that you can use this kind of model again and again and make different changes to it to fit your local system. So one of the scenarios that people wanted to look at is, well, what happens if the progression, based on the research, if the progression is different from state to state, depending on whether you're diagnosed or undiagnosed, and if you're undiagnosed, you're more likely to progress more quickly, then what happens if we diagnose more people at the mild stage, in those new cases, who of course will be then accessing those initial services, which at the moment they're not accessing, and what's the difference then in cost as against their likelihood of progressing not quite so fast. So let's just run that one through, and I'll run it very fast so that a bit faster. Oops. So we can then have a look at the results. So I hope that's making sense to everybody if that runs through now. And you can see from the visuals what's actually going on within simulation and how it might be useful to more than one site. So we're just coming up to the end of year 3 now. And this then allows us to compare the results of the current run with the previous run, and also to see whether our costs have changed. And what we can see from the current run is that our costs are slightly more in our total costs are slightly more in year 1. And we can have a look at how different people are using those services and what state they're in. So we've got slightly less people by the end of our run who are in care homes in year 3 than we did in the scenario where people were, we didn't have so many people who were diagnosed. So it's allowing people to test out the different interventions based on the likely disease progression and understand that in terms of cost and activity. So I wanted to come on to think about what the key features are of any disease pathway. I'm sharing our experience of working with many people over the years in developing these pathways. And so we've come up with some key features we think are important, but we'd love to hear from you about your thoughts, and we've created a survey that we'd love you to fill in and let us know what you think the key features are, and we'll report back to everybody what the general thoughts are. But what I wanted to put to you really was the idea that we have about being able to have these simulated pathways, which include demand from population health predictions and disease progressions and the best clinical practice, which is evidence-based, which are localizable to providers and populations, that would enable numbers of different sites to answer the same questions, which most people are looking at. What happens if I implement the best practice? What's it going to look like in the future? What resources will I need? What are the financials? What are the patient weights? What are the patient outcomes? But when you're looking at a disease pathway which actually behaves in the same way and is only really stopped by the different interventions that you might be putting in place, it does seem to us that actually there's a real opportunity to create something that could be used in multiple places. And to that end, we've been creating a tool that will enable you to share and manage pathways on the web. And the idea would be that you would be able to upload a similar sort of pathway to the ones that I've shown and just sign into that account and, with your own login, and then have multiple logins so that actually people could access and use a suite of simulation models. So here's the example of how it would work. You'd have your models uploaded, and you could access the ones that you want, but you could also not just run those models, but you could change them, you could save them, you can export your results, and you can share them with others. So if you are in these different areas and you wanted to share your results with everyone in your locality, then you would be able to do so, and then people could change them and upload them, and in that way you could share and really have this virtual discussion about different pathway models across a whole community and indeed beyond. And this is really how it would work. You'd create your localized simulations, and you'd make sure that only the users you wanted to see them could see them. So we had this concept, and this was in the NHS, of do once and share, and we think this really embodies that. And in order to make this a reality, our offer to you from this webinar is to help us build pathways that we can share, so we can test this concept with our simulation community. And what we'd like you to do is to send us your pathway suggestions. What we'll do is we'll choose one to build and share using this technology, and then we'll ask you to use them and see what you think. So if you've got ideas for a pathway that could be sufficiently generic, that's based on the disease progression, and you think it would work for this purpose, then do please email us at healthteam@simulate.com, and we'd love to hear from you. So that's the end of this webinar. Thank you very much indeed for listening. I hope you found it useful. If you want to see any other topics covered, please do email me at the email address there. You might have some examples of work that you've done that you'd like to share, and we'd love you to host you to talk about your particular simulation. Do, as always, continue the discussion on our LinkedIn group, Simulate in Health. We've had some lively discussions there about some of our webinars, and do please feel free to join in those and ask any questions. And I'd just like to let you know about our September workshop. We'll be sending details out about that soon, but we're looking at optimizing outpatient operations, specifically looking at staffing and scheduling. So moving to a more operational set of questions for the next webinar. Thank you very much indeed for attending, and look forward to hearing your suggestions back. Bye.